with the World Hepatitis Day, which is being celebrated on July 28th. PMS College of Dental Science and Research have always been at the forefront and is a leader in imparting quality dental education, value-based education, and also at the forefront in hosting quality-based webinars under the able and dynamic guidance of our beloved chairman, Dr. P.S. Taha. World Hepatitis Day is observed each year on 28 July to raise awareness of viral hepatitis, an inflammation of the liver that causes severe liver disease and hepatocellular cancer. This year's theme of the year 2021 is that hepatitis can't wait, conveying the urgency of the efforts needed to eliminate hepatitis as a public health threat by the year 2030. With a person dying every 30 seconds from a hepatitis globally, even in the current COVID-19 crisis, we can't wait to act on hepatitis A, B, C, D, and E. WHO had identified hepatitis as a major health concern for India. As per WHO statistics in India in 2020, about 4 crore people were chronically infected with hepatitis B and 60 lakh to 1.2 crore people were infected with hepatitis C. According to Indian Journal of Medical Research in India, about 2.5 lakh people die every year due to viral hepatitis or its sequelae every year. July 28 is marked as the birthday of Nobel Prize winning scientist Dr. Baruch Bloomberg. To honor him, we are commemorating July 28 as the World Hepatitis Day. Today, we have 2 resource persons for the day, Dr. Shifi Fasal, who is the District Nodal Officer of Alapi Government Medical College. Dr. Rafida K. She is the COVID Nodal Officer and in the Molecular Diagnostic Laboratory and is also the Associate Nodal Officer for Travancore Medical College, Kollam. So now, at the beginning, may I invite Dr. Ambali, who is the Director of Research and Professor, Department of Periodontics, to say a few words about the launch of our institutional journal, Journal of Maxillofacial Science and Research. Madam.
Thank you, sir. Respected Chairman, Dr. P.S. Taha, Principal, PG Director, colleagues, and dear students. PMS College of Dental Science and Research is now restarting our official publication titled Journal of Maxillofacial Science and Research as part of improving our research and publication activities of our faculty as well as students. The journal will be an excellent platform to showcase our research work in dental specialties as well as related sciences. We can also publish new, interesting, and rare cases, and being an academic institution, we are giving priority to interdisciplinary cases with proper management. I would like to express my sincere gratitude to our beloved chairman, Dr. P.S. Taha, for giving me an opportunity to edit this journal. And I also thank all the editorial team members for their hard work and enthusiasm, and the administrative team for their constant support. I request all the faculty members and undergraduate and postgraduate students to support the journal by contributing good quality articles. Now, I request our beloved chairman, Dr. P.S. Taha, to officially release our journal. Sir.
Taha, sir?
Taha, sir?
Yeah, one second. Yeah, good evening, everybody. I'm really happy that, we are, restarting the launch of the new journal of maxillofacial research. As we all know, the importance of journals, and institutional journals is an important thing where it gives an opportunity for our students, postgraduates, and the faculty to contribute and learn more about the topics. And I think this is a real platform where I can do this job, though from away from the institution. I can do this job during the webinar session, which is conducted by PMS College of Dental Science and Research. I wish I would have been, there at the college, for physically, releasing the journal. but we know the situations are not conducive for us to be there. And understanding the situation, I'm really happy to, release the journal, the institutional journal. And I thank Dr. Ambali, Dr. Rajesh Pillai, and all other team who have contributed to the release of this journal. Thank you. Thank you very much.
Now, may I request Dr. Sheena N for introducing the first speaker of the day, Dr. Rashida K.
Thank you, Dr. Rajesh Pillai, sir. Good evening to all of you. Respected Chairman, Dr. P.S. Saha, sir, our Principal, PG Director, esteemed speakers of the day, Dr. Rafida KM and Dr. Shifi Fassal, and dear colleagues, it's my immense pleasure and honor to introduce speaker of the day, Dr. Rafida, a topic entitled Hepatitis B in Nutshell, the Basics. Dr. Rafida completed her MBBS from Malangara Orthodox Syrian Church Medical College, Kolancheri. She obtained her MD in microbiology from Government Medical College, Trivandrum. Currently, she is the Associate Professor of Microbiology and Hospital Infection Control Officer at Travancore Medical College, Kollam. Additionally, she is post of Board Nodal Officer, Molecular Diagnostic Laboratory, Travancore Medical College, Kollam. I welcome you, ma'am, for the lecture. Thank you.
Thank you, Dr.
Sheena, for the kind words. Respected Chairman, Dr. Taha, respected faculties of PMS Dental College, a very good evening to one and all. Today, I'm very glad to present the topic, hepatitis, on this special day, that is World Hepatitis Day. And I think it's my pleasure to present this topic. And also, I'm very glad to know that PMS Dental College has come with journals, new journal for your own institution. That's a very good thing. And now I think I'm not going to, I'm slightly going to the topic. Shall I start screen sharing?
Yes, ma'am. Yes, madam.
Okay. And special thanks to Deepa, who gave me this opportunity, and Dr. Afzal. Can you see the screen now? I have started sharing.
Ma'am, you may go ahead, ma'am. You can open the PowerPoint. Yeah, Sujit, make her the co-host act. Sujit, are you there?
Sir.
Sujit, പുള്ളിക്കാരി ഒന്ന് co-host ആക്കിയാലേ ഷെയർ ചെയ്യാൻ പറ്റുള്ളൂ.
Host ഷെയർ ചെയ്തു മാഡം, അത് PPT ഒന്ന് ഷെയർ ചെയ്താൽ മതി മാഡം. മാഡം ഇപ്പൊ അതാ ഷെയർ ചെയ്തേക്കുന്നത്.
Sir, already she is a co-host.
Share it.
മാഡം PPT ഓപ്പൺ ആക്കിയിട്ട് ന്യൂ ഷെയർ കൊടുത്തിട്ട് PPT സെലക്ട് ചെയ്താൽ മതി.
Okay, of the slide is clear now. So this year, the topic for World Hepatitis Day is Hepatitis Can't Wait. That is the theme for World Hepatitis Day. So So what does it mean? Hepatitis can't wait. Nowadays, there is increasing number of hepatitis B cases. Why you want to know more about hepatitis B is that in healthcare workers, there is a chance of increasing, there is increased risk for a transmission in healthcare workers, and that can lead on to cirrhosis, hepatocellular carcinoma, and all. And even in this current COVID-19 crisis, every 30 seconds, a person died due to hepatitis related illness, that is due to cirrhosis or hepatocellular carcinoma. And our aim is to eliminate hepatitis as a public health threat by 2030. So we can't wait for diagnosis of hepatitis B. We can't wait to start vaccination. We can't wait to prevent transmission from mother to child. So that's a theme that is selected by WHO for World Hepatitis Day this year. Okay, so I have already explained why it's important. It's a potentially life-threatening liver infection caused by hepatitis B virus, and it's a major global health problem. Okay, and another thing is, now there is a pandemic of COVID-19. We know all about TB and all, but hepatitis B, it may be undiagnosed. And from my experience, what I have seen is, when a patient comes for screening or any other surgery and all, when we check for hepatitis B surface antigen, we may get positive. So it may get undiagnosed. So our aim is to detect maximum number of cases. And another important thing is that it is a viral disease that can lead on to cancer, and there is vaccine available. So we can use the vaccines to prevent this transmission. Okay. And the chronic infection and death is usually from cirrhosis and liver cancer. And this is the statistics. WHO estimates that around 296 million people were living with chronic hepatitis B infection in 2019, with around 1.5 million new infections every year. And in 2019, hepatitis B resulted in an estimated 820,000 deaths. That is mostly from cirrhosis and hepatocellular carcinoma. And we can actually classify areas based on the prevalence of hepatitis B as low endemicity area, intermediate endemicity area, and high endemicity area. If the carrier rate is less than 2%, it is known as low endemicity area. For example, American and European regions, and also in Australia. So there is another entity that you must know is, if at all, if the patient is not having any infection, there are carriers. Usually it is undetected. So that's another reason for transmission. And intermediate endemicity is when the carrier rate is between 2 to 8%. And you must remember, India is an intermediate endemicity area. India and China belongs to intermediate endemicity area. And high endemicity means when the carrier rate is more than 8%, for example, Africa and in Western Pacific regions. Okay, so in India, I said India comes in intermediate endemicity area. So the prevalence is around 4%. The highest is in Andaman and Arunachal Pradesh, and 40 to 50% of hepatocellular carcinoma and 10 to 20% of cirrhosis is due to hepatitis B. Now, when we observe World Hepatitis Day, we have to think of other causes of hepatitis also. And it's not only the viruses, not only hepatitis B virus that cause hepatitis. It could be due to toxic substances. As you all know, alcohol and excessive use of NSAIDs. These can lead on to hepatitis. And another one is autoimmune diseases and metabolic diseases. But viruses are the most common cause of hepatitis. That's why we are giving more importance for viral hepatitis. Viruses could be, it's not only hepatitis B or hepatitis C. There are actually, when we read about the history of hepatitis and hepatitis viruses, these were the disease was present for hundreds of years back, but the virus was discovered recently. But still, if you read many books, you can identify that hepatitis was there for many years, and it could be due to hepatitis A or hepatitis E. These are transmitted by fecal-oral route or transmitted by food or water. So, and also it will not lead on to hepatocellular carcinoma or cirrhosis. So if at all it causes hepatitis, it causes jaundice, but the mortality is very less. So that's why we are not going to explain about hepatitis A or hepatitis E. But you should not forget that I am mentioning this in this now because I could see that lots of students have joined. So it will be useful for you also. Okay, it's not only hepatitis B, which is transmitted by bloodborne. It's due to hepatitis A or E That could be from fecal-oral route. And then hepatitis B and hepatitis C. These can lead on to hepatocellular carcinoma. These are transmitted by blood, mainly not only by blood, parental, it could be from due to sexual transmission or parent to child, mother to child transmission is there. Another one is hepatitis G. And you know, hepatotrophic viruses are a group of viruses that affect liver. But not only this hepatitis virus, even yellow fever virus, Epstein-Barr virus, all these viruses can affect liver. But the peculiarity of infection produced by this group of viruses are similar. That's why these viruses are grouped under hepatitis viruses. And all these viruses are RNA viruses except hepatitis B. Hepatitis B is a DNA virus. As Rajesh Pillai sir already said, it was the virus, hepatitis B virus was discovered in 1965 by Dr. Baruch Blumberg, and he got Nobel Prize for his discovery. Actually, today is his birthday. That's why we celebrate today as World Hepatitis Day. And basics like hepatitis means inflammation of liver, and it can be like an acute liver disease, jaundice, or it could be severe liver disease and hepatocellular carcinoma. And so far we were telling about what is hepatitis B. Hepatitis could be due to many viruses, and I mentioned the prevalence of hepatitis B and why it is important. Why it is important is it is transmitted. If at all it's a carrier, it can get transmitted, and also in healthcare workers, risk is more. Now I am coming to the basic structure of hepatitis B. It belongs to the family Hepatinaviride. It's a complex 42 nanometer double shell particle, and it's an enveloped virus. Okay, the envelope has got hepatitis B surface antigen, and for all viruses, the structure is similar. Okay, all viruses have got a protein coat, and inside there is nucleocapsid. Okay, a nucleocapsid surrounded by a protein is the basic structure of virus. It could be hepatitis, corona, any virus. So it's no different, but it has got an envelope, and this envelope has got hepatitis B surface antigen. I think you will be knowing more about surface antigen and all, because you know for every procedure you'll be screening the patient for hepatitis B surface antigen. That is what we usually detect for screening also. And then it has got a nucleocapsid, and this genome is a circular, partially double-stranded DNA, and it has got DNA polymerase. Okay, so all the hepatitis viruses are RNA virus except hepatitis B virus. Usually DNA is double-stranded, but here it is partially double-stranded DNA virus. This is the structure of hepatitis virus. It has got an envelope, and it is a surface. Okay, so this is only common sense. So hepatitis B has got a surface antigen. This outermost one is the hepatitis B surface antigen that is secreted into circulation, and inside to the surface antigen we have hepatitis B E antigen that is also secreted, and there is hepatitis B core antigen. Okay, so this core antigen is in inside, so it is not secreted. So when you are trying to diagnose a case of hepatitis B, you will be getting hepatitis B surface antigen only. We are not going to get this C antigen which is there inside. And definitely we have this nucleocapsid and a partially double-stranded DNA. And for multiplication, an enzyme is necessary, that is DNA polymerase enzyme. Hope the structure is clear. So hepatitis B has got a surface antigen, E antigen, a core antigen, and the nucleus with nucleocapsid, and it is partially double-stranded DNA. Okay, so this hepatitis B surface antigen that is usually detected for screening purposes is an envelope protein. It is made of epitopes A, D or Y, and W or R. What you must understand is this A is common for all. So we can have ADW, ADR, AYW, AYR, AWR. Sorry, AYR. So these are the combinations of serotypes that is present in hepatitis B. But this A is common, so if at all we give vaccine, it will be effective for all. A is common for all. Now coming to the core antigen, which is inside, and it is not detectable in patient's blood. You can detect it by immunofluorescence in liver, but you cannot. It is not secreted in blood, so you can't find it out. Then hepatitis B pre-core antigen is hepatitis B E antigen that also appears along with hepatitis B surface antigen in blood. So that's also an antigen that can be detected by serological methods for diagnostic purpose. This is the electron microscopic picture of hepatitis B. You can see the spherical particle. Okay, this is the electron microscopic picture of ordained particle that is seen. Circular particle. This is hepatitis B. Some tubular form and some ring forms are also there. So this is the electron microscopic picture of hepatitis B virus. Already I have mentioned we have 4 combinations, 4 serotypes of hepatitis B. In India, ADR is seen in South and East India, AYW in Western and Northern India. Usually we don't do this much for research purpose and all, to know which actually it is for epidemiological purpose only. If there is an outbreak of hepatitis B or something like that, to know whether which strain is causing this, you can do this. And there are 10 genotypes A to J, genotype A, B, C, D, like that to J. Genotype D followed by A is prevalent in India. And the viral genome, it has got S gene that code for hepatitis B surface antigen, then C gene, X gene, and P gene. Just for completion sake, I'm showing this hepatitis B surface antigen. S itself pre-S1, pre-S2, then S, then pre-core, core, X, and polymerase P. And sometimes there can be some hepatitis B virus mutants. Actually, this is in pre-core region. Okay, this pre-core region that will code for hepatitis B E antigen. If there is a mutation, that will not be seen in blood. And sometimes there can be mutation in S gene. Okay, S gene mutation lead to escape mutants. In that case, you will not be able to find hepatitis B surface antigen in blood. So you will be seeing anti-HPC, everything will be there, but surface antigen will not be there. And another one is YMDD mutation. It is due to lamivudine therapy and all. So you know how it is transmitted. Hepatitis A and E are transmitted by fecal-oral route, that's by blood, food and water. But this is mainly by parenteral route, then perinatal from mother to child, sexual route, and sometimes by direct skin contact. Mainly it is blood and blood products, transfusion, and also by needle prick injuries. That's why we are all concerned about hepatitis B, because it is transmitted by blood and blood products and also by needle prick injuries. And inoculation during surgical or dental procedures, or percutaneous inoculation via shared razors and toothbrushes. And vertical during delivery, there is maximum risk, and also by breastfeeding. Sexual in developed countries, homosexual males, and it is secreted in body fluids like semen and vaginal secretions. And if there is an infected open skin lesion, there can be transmission by skin contact. And so spread by needle stick injury, tattooing, piercing, exposure to infected blood and body fluids such as saliva, menstrual, vaginal, and seminal fluids. All these are the transmission methods. In dental practice, transmission is by blood, saliva, clavicular fluid, nasopharyngeal secretions, and higher concentrations of hepatitis B and hepatitis C viral RNA are found in the gingival sulcus than in saliva. So when in dental practice, it's very important to take all precautions. I think all the students are vaccinated against hepatitis B. You know, the vaccine is around 98 to 100% effective. And so that's why vaccination is important. So we have come to the clinical features. So the incubation period is around 6 weeks to 6 months. And the onset is insidious but severe. Fever is less common. Slow grade fever only will be there. And jaundice, that also will be rare in children. So clinical features are very less. That's why it's usually underdiagnosed. Viral infection, all viral hepatitis, acute and chronic. And acute, there can be complications also. Sorry, chronic, there can be cirrhosis and liver cancer. Acute, the phases are icterus means jaundice. Pre-icteric phase means before jaundice, there is malaise, anorexia, weakness, myalgia, nausea, vomiting, and arthralgia. During icteric phase, if the patient is in icteric phase, there will be jaundice. And after that, convalescent phase, long, malaise, and fatigue will be there. Uncomplicated hepatitis for 8 to 10 weeks. Mild symptoms will be there for more than 1 year. And coming to the hepatic complications, usually cancer is caused by many reasons, and there are some infective causes of cancer. And the first virus that was found to be associated with cancer was hepatitis B. And later now we have hepatitis C and also this Epstein-Barr virus, human papilloma virus. All this can cause cancer, but this is actually history. Like a cancer can be prevented by vaccine. That is the advantage of knowing about this hepatitis. Complications are fulminant hepatitis, cirrhosis, hepatocellular carcinoma. Extrahepatic complications are prodromal phase. There can be serum sickness-like syndrome due to immune complex deposition. So that's about the clinical features. So there can be normal viral fever, illness like fever, myalgia, vomiting. Then there can be jaundice. Then it can lead on to complications like cirrhosis or hepatocellular carcinoma. Actually, hepatocellular carcinoma, one of the most important cause, most common cause is hepatitis B. Now coming to the laboratory diagnosis. As the theme says, we can't wait. So we can't wait to diagnose and treat, or we can't wait to prevent this infection. So there are many diagnostic tests available. You will get the result within 30 minutes. So the antigen markers used for hepatitis B surface antigen and hepatitis B E antigen. Then antibody markers are anti-HBs antibody, anti-HBe antibody, and anti-HBc antibody. Then the gold standard is PCR, molecular markers. If you are finding out the hepatitis B viral DNA, the nucleic acid particle, that is confirmatory. Then for every jaundice, for all types of hepatitis, viral, toxic, metabolic, for all these, there will be elevated liver enzymes and elevated serum bilirubin. And so how can you find out these markers? So the markers are antigen markers like surface antigen, E antigen, antibody like anti-HBs, anti-HBe, and anti-HBc, then molecular markers, non-specific markers. So how can you find it out? It's by enzyme-linked immunosorbent assay, ELISA, or immunochromatographic test, which is a rapid test, then chemiluminescence assay, enzyme-linked fluorescence assay, or polymerase chain reaction, but it does not grow in culture system. And for viruses, we use culture system only for research purposes, not for protein diagnostic purpose, but also for vaccine production. But this vaccine is not by culture, it's engineering method. So we cannot grow this virus by culture. Okay, so we have many serological tests available everywhere. Rapid test, immunochromatography, sorry for the spelling mistake, it is immuno, 2M are there. Immunochromatographic test, ELISA, chemiluminescence, alpha, and PCR. PCR is the gold standard. Why? Because we can identify the pathogen as its own, and also we can know the viral load. The viral load can be determined by real-time PCR. So coming to the basic markers, hepatitis B surface antigen is the first marker to be elevated following infection. It appears within 1 to 12 weeks. Okay, so that indicates the onset of infectivity. So if you are getting a person with hepatitis B surface antigen elevated, you can, the inference is that the patient is infectious. Okay, and it remains elevated in the entire duration of acute hepatitis. And after 1 to 2 months after onset of jaundice, it will be undetectable. And this is the epidemiological marker of infection. If you want to conduct a study on prevalence of hepatitis B, what you have to do is you just have to take blood samples, separate it as serum, and you just check hepatitis B surface antigen. If it is there, it is indicative of hepatitis B. So that is used as an epidemiological marker of infection. And hepatitis B pre-core antigen or E antigen and DNA, and this indicates infectivity. Okay, appear concurrently with or shortly after appearance of hepatitis B surface antigen in serum. It's a marker of active viral replication and high viral infectivity. So if you are getting E antigen or DNA, hepatitis B viral DNA, that indicates infectivity is more. That indicates actively multiplying virus. That is acute active hepatitis or chronic active hepatitis. Then core antigen, I already said, it's there inside, so you will not be able to find hepatitis B, C antigen if it cannot be detected in blood. And anti-HBc IgM, that is hepatitis B core antibody, can be detected. So this is the first antibody to be elevated following infection. So the first antigen that is elevated is hepatitis B surface antigen. And the first antibody that can be detected in blood is anti-HBV IgM antibody. It will appear within first 1 to 2 weeks after appearance of HBsAg and last for around 3 to 6 months. Then anti-HBe, that is hepatitis B pre-core antibody, after the clearance of HBe antigen and remain elevated for variable period and diminished viral replication and decrease infectivity. So after that, anti-HBe antibody will come, then anti-HBs antibody will come. It appears after the clearance of HBe antigen and remain elevated indefinitely. And it indicates recovery, immunity, non-infectivity, and vaccination. So if you take blood samples and you detect only anti-HBs antibody, it indicates that now in current scenario, it indicates that you have vaccinated, your vaccine is effective. Okay, so in vaccine, we are giving the surface antigen, and if antibody is there, that indicates you are immune or you are vaccinated. Just to show the graph. So initially it is the hepatitis B surface antigen that is elevated, then it comes down, then antibody, anti-HBs antibody will be there. And immediately after that you have HBe antigen, okay, that gets elevated, fall down, and then again anti-HBe antibody. But you cannot find this HBc antigen. Instead of that, the first antibody to be elevated is, these are the antibodies, anti-HBe, anti-HBs, this is anti-HBc antibody, that is the first antibody to be elevated. And DNA polymerase will be, you can detect DNA polymerase. Now, the thing is that there is no definitive treatment for hepatitis B. It's always first, second, third, always it is prevention and prevention. Okay, so acute hepatitis B infection among previously healthy adults, recovery is in 99%, antiviral is unnecessary. And it is indicated when there is acute hepatitis with acute liver failure, chronic active hepatitis, chronic inactive hepatitis, higher viral load, there comes the importance of PCR. Then if there is cirrhosis, carriers with family history of cirrhosis or hepatocellular carcinoma. Otherwise, treatment is not needed. Actually, only this nutrition, better nutrition, fluid intake, then avoidance of unnecessary medications like paracetamol and medication against vomiting should be avoided. And it can just slow the progression of cirrhosis and reduce the incidence of liver cancer and improve long-term survival. In 2021, WHO estimated that 12 to 25% people with chronic hepatitis B infection will require treatment, depending on setting and eligibility criteria. Treatment given are nucleoside analogues like tenofovir, entecavir, or lamivudine. Actually, hepatitis B and HIV infection can be there together, so treatment can be given like that. And just for completion's sake, like it is World Hepatitis Day, it's not only hepatitis B that is transmitted by blood, it's also hepatitis C. But the thing is that we don't have a vaccine for hepatitis C. So that's why we are not highlighting to hepatitis C, but we are not supposed to forget it. So that's why I have included hepatitis C also. It's a bloodborne virus. Infection through exposure to blood from unsafe injection practice, same transmission, unsafe healthcare, unscreened blood transfusion, injection drug use, sexual practices. Around 58 million people have chronic hepatitis C virus infection, with about 1.5 million new infections occurring per year. And in 2019, around 290,000 people died due to hepatitis C. Okay, and it can lead to cirrhosis and hepatocellular carcinoma. Antiviral medicines can cure more than 95% hepatitis infection, but access to diagnosis and treatment is low. In the front can be given even for hepatitis B and C. Okay, there is currently no effective vaccine against hepatitis C. That's the problem. We have vaccine, which is very effective against hepatitis B, but we don't have a vaccine against hepatitis C. So to conclude, as I said in the beginning, we can't wait for hepatitis B birth dose to give hepatitis B birth dose for newborns, and testing for viral hepatitis, testing of pregnant mothers, and funding hepatitis services. So we can't wait for anything. We just have to act. That's the take-home message. And as dental practitioners and students, it's very important to know about hepatitis B, how it is transmitted, and how in healthcare workers, how it is what are the precautions to be done, what are the standard precautions, what will you do when there is needle stick injury, what will you do when there is an exposure with hepatitis B. Dr. Shifi will be talking about it. Once again, thank you all. Thank you, Dr. Taha sir, Chairman, PMS Dental College, Dr. Sudeep sir, Principal, Dr. Rajesh Patel sir, Director. So Rajesh Pilla sir, sorry sir, Rajesh Patel sir is our professor. Dr. Sheena, Dr. Smita, and also Deepa, who gave me this opportunity. Yeah, thank you again.
For the wonderful lecture and her insight on the basics of hepatitis B. We really enjoyed listening to your insights. Thank you, madam.
Thank you, sir.
So now we invite Dr. Smita C to introduce the next resource person of the day, Dr. Shifi Fasal. Dr. Smita, are you there?
Sir, am I audible?
Yeah.
Respected Chairman, Dr. Taha sir, the distinguished speakers of the day, my dear colleagues and dear students, a warm good evening to one and all. First of all, my heartfelt congratulations and best wishes for the launch of our institutional journal, Journal of Maxillofacial Science and Research. I am extremely overwhelmed to get this opportunity to introduce our respected speaker of the session, Dr. Shifi Fasal. Dr. Shifi is currently working as Assistant Professor, Department of Transfusion Medicine, Government Medical College, Alappuzha. She completed her graduation from Government Medical College, Alappuzha, and her post-graduation in Transfusion Medicine from Government Medical College, Trivandrum. She is also holding the post of District Nodal Officer of Alappuzha under Blood Safety Program of Government of Kerala. I would like to extend a special welcome to you, ma'am, and we are eagerly waiting to grab this valuable session, Hepatitis in Clinic. Over to you, ma'am. Thank you.
Thank you, Dr. Smita, for your words. Respected Chairman, Dr. Taha sir, Principal, Dr. Sudeep sir, Director, PG, Dr. Rajesh Pilla sir, and all other eminent faculties and students. It's by a pleasure to present this topic. I would like to say some words about my topic, because this is a fundamental topic. I think this is a fundamental topic in healthcare system, that is biosafety in healthcare. The importance of this topic is that it is a universal topic for all the health workers. What I mean is that so it is I already said it's a fundamental topic in healthcare system, because this is the topic which should be known by all the healthcare workers. What I mean is that from doctors, from the staff, from the nurse in your clinics, from the lab of the lab personals, and even the cleaning staff in your clinic. So let me start my topic.
Madam, you need to enlarge the slide, ma'am. There is a small button at the bottom. I think you need to, yeah.
Okay, now what is biosafety? It is the application of a combination of safety equipments, safety practices, and safety environment while working with potentially infectious microorganisms. So why there is a need for biosafety practice? So protection of, I already mentioned, the workers, the products, the co-workers, and the lab support personnel, and also the environment. So as we all know, there are 4 levels of biosafety: 1, 2, 3, and 4. One is the material, when we are dealing with material not known to consistently cause disease in healthy adults. BSL-2 means it is associated with human disease. Hazard is from percutaneous injury, ingestion, or exposure to mucous membrane, or whatever like that. BSL-3 is indigenous or exotic agents with potential for aerosol transmission. The disease may be serious or have lethal consequences. And BSL-4 is dangerous exotic agents which pose a high risk of life-threatening disease, aerosol transmitted lab infections, or related agents with unknown risk of transmission. So we are really concerned about this we need biosafety level 2, because most of the diseases we are dealing with this comes under BSL 2. So which are the modes of exposure? We all know during the collection or during the procedures, it can be the transfer of the specimen or the processing or the cleaning, which is very important. And also the most important part is the disposal of waste. So what are the modes of transmission? Already Dr. Rafida has mentioned: needle stick injury, cuts, splashes, aerosols, inhalation, accidental ingestion, or ingestion. Now coming to the risk assessment, it depends upon so many factors. Pathogenicity of the material, that is the disease incidence and severity. That means whether that particular disease is prevalent in our population. Then infectivity of the reagent. Then routes of transmission, that is via just parenteral, airborne, or ingestion. The number of exposures we had, the agent stability, that is ease of contamination, whether it is viable or not in the environment. Then concentration, the infectious organisms per volume, availability of effective prophylaxis like hepatitis B vaccine, then medical surveillance, exposure management, then skill level of staff, which is a very important matter. That is why I already mentioned in the in my introduction that this is a topic which need to be discussed among all the category of the healthcare workers. Now, let me give you a comparison of the infectivity and the concentration of 3 major viruses which we are concerned about: HIV, HBV, and HCV, hepatitis B, hepatitis C, and HIV. The infectivity of HIV is around 0.05 to 0.3%, whereas that of HBV is around 3 to 10%, and HCV is around 30%, and the concentration is already mentioned in this slide. Now, coming to the risk of activity, same agent can have different containment levels at different stages. Procedures that produce aerosols have higher risk. Procedures using needles or other sharps have high risk. Handling blood, serum, or tissue samples may have low risk. So a risk of human blood and serum. The closer the relationship between the host, the higher will be the risk. So while dealing with human blood, tissue, and fluid, use BSL-2 work practices and procedures, additional requirements for HIV work. Everyone needs to be offered the hepatitis B vaccine, and develop specific exposure plan, SOPs. Specific training is important. Then review needle or syringe use and replace with safer modern devices. Then exposure incidents must be followed up. So coming to my key topic, what are the good practices to be followed in your clinic? The first one is general hygiene practice, then universal precautions, which is now renamed as standard precautions, then safe handling, then management of emergencies, which includes spills, needle stick injuries, then hepatitis vaccination of all category of staff and post-exposure prophylaxis. So coming to the general hygiene practice, hazard-free workplace is a necessity. That is, the clinic design should be like that. Appropriate clinical design and facilities, and the lab door should be closed with biohazard label, no unauthorized entry, safety equipments, good housekeeping, restricted areas with warning signs. So which practices are not permitted in lab? Eating, drinking, smoking, handling contact lenses, pipetting by mouth, storing food and drink. Always wash hands after handling microorganisms, after removing gloves and before leaving lab. So some students have a misconception that gloves can be used instead of washing hands. It is not like that. After removing your gloves, you should always wash your hands. Then only you should be out of your clinic. Perform all technical procedures to minimize the aerosol formation. Disinfect workplaces at the end of each working day with hypochlorite solution. Place contaminated objects in hypochlorite solution. It should not be left unattended in the working bench. So what happens if you do like that? Some other cleaning staff will come and they don't know whether it is contaminated objects or not. So they will handle it. You don't know whether they are wearing gloves or no. So for the safety of our co-workers, we should practice these general hygiene. So coming to injection is the main what you say. It's a major intervention which is done in any clinic, whether in medical or in dental or whatever it is. So what makes an injection unsafe? You all know these things: reuse of syringes and needles and other injection equipments. I think which is not practiced now. And overuse of injections, then lack of clean workspaces and hands, unsafe collection and disposal of used injection equipment. I think among these 4 points, one is not at all practicing now. Most of the time it is disposable syringes. But second, third and fourth points are very important because these are still causes which makes our injection practices unsafe. Already I have mentioned this. And coming to what are the safe injection practices? Avoid passing of needle from one person to another. Avoid trying injection in an agitated, restless patient. Reduce the distance between injection preparation and injection giving. Reduce the distance between injection giving and injection waste disposal. Pierce the septum of a multi-dose vial with a new sterile needle. Never leave a needle in place in the stopper of a multi-dose vial. Use pop-open ampules. If you use an ampule that requires a metal file to open, protect your fingers with a small gauze pad. Inspect and discard medications which are visibly contaminated or damaged. Always follow the instructions for use, storage, and handling. Discard a needle that has touched any non-sterile surface, especially your fingers. So we all know these practices. Never recap, bend or break needles, discard needles or sharps into it should not be done. Never discard needles or sharps into biological waste. Never discard needles into regular trash. I have already given a picture in this. What happens if we discard this our needle in this regular biological waste? What happens? The cleaning staff, which takes this do the segregation collection, will get exposed. So discard needles, razor blades and scalpel blades into red puncture resistant sharp containers. Never dispose of broken glass into broken glass containers, never into regular trash. So this practice should not be followed. 2 full is unsafe. Only 3/4 should be filled. Now, coming to next important thing is universal safety precaution. What does this mean? It means treat all human blood and unfixed tissue as if it contains HIV, HBV, or HCV. Dr. Rafida has already mentioned this graph. Let me introduce one entity, that is window period. Why we are concerning, students usually say we are already checked the HBV, HCV, HIV status before the procedure. Then why are we following this universal precautions? It is because there is an entity called window period. There is no test is 100% foolproof. There is a gap. That is the time taken for the detectable markers to appear in the serum. So, and that time the patient will be, so the so-called the person who is coming for the procedure will be infected, but we are not detecting his seroconversion status. So, you should be very careful about that situation. Then another is occult HBV, which is actually the HBs AG mutant. Even if he or she is positive, the HBs AG tests which are available now, routine tests, serological tests which are available, which we usually do before the procedures in our clinic, that will be negative. But this can be detected by molecular methods, but we are not routinely doing molecular methods. So this can be another cause. So because of these entities, because of these loopholes, we are forced to, the healthcare workers are forced to follow the universal precautions. So which include, you all may be knowing that personal protection, which includes use gloves to avoid contact with blood or body fluids, discard gloves when contaminated or damaged, then wash hands and put on new gloves. Do not touch your eyes, nose, or other exposed surface or articles like doorknob, pen, telephone with gloved hands. Use of personal protective equipments like gloves, apron, gowns, mask, eye goggles. These are the proper steps for removing the gloves. See how the finger is inserted into the gloves before removing. So already mentioned protective clothing, usually required in areas depending on the procedures or policies of the area. Remove the protective clothing when leaving the clinic. Then coming to eye protection, if we are suspecting a risk of splash blood or body fluids, safety glass, safety goggles, or face shields. Then another important point is segregate the high risk activities from low risk. Disinfect the bench top, other areas, and what all cut and abrasions in your skin should be covered before you enter your clinic. Then even if we practice all these things, there can happen emergencies. So how we manage these emergencies? Always we should develop and practice plans for accidental spills, accidental exposures, which includes needle stick injury, eye or mucous membrane splash, or breathing aerosols. So accidental spill, what we have to do is immediately report to your concerned authority if it is in your hospital. Then treat serious injuries before attempting to contain the spill. Evacuate the area immediately if exposure to aerosolized microorganisms or disinfectant, and leave it for 20 minutes for the action to occur. Collect all the spill and contaminated material by forceps and dustbins, not using your hands. Decontaminate the waste and disinfect the tools used for cleaning. And another important point is, if a spill occurs, immediately what we have to do is that you should post a danger in that area. That is, the access to the area should be restricted to personnel. Access to the cleanup area should be restricted to the personnel involved in the cleaning process only. And the entire area should be cleaned of all the fluids using a disinfectant. Then use disposable towels to soak up the infective material and properly dispose of immediately after use. And be always alert for sharp objects like broken glassware, used syringes, Do not pick these up. Use a brush or a broom or a dustbin. Then clean up procedures. And put all these contaminated towels and waste in a sealed, color-coded or labeled leak-proof container and discard as per biomedical waste management rule. Then coming to the needle stick injuries. How do these needle stick injuries occur? Usually at the time of disposing the needles or overfilling containers or emptying sharps container rather than disposing once filled, administering injections, drawing blood, recapping needles, handling trash and dirty linens. So which are the categories of exposure? Mild exposure, moderate exposure, and severe exposure. Mild exposure means mucous membrane or non-intact skin with small volumes. Moderate exposure means mucous membrane or non-intact skin with large volumes or percutaneous superficial exposure with solid needle. Severe exposure means percutaneous with large volume, an accident with a high caliber needle that is more than 18 gauge, visibly contaminated with blood, a deep wound, transmission of a significant volume of blood, an accident with material that has been previously used intravenously or intraarterially. So, which are the do's and don'ts of management of needle stick injuries? Wash with soap and water immediately. Then wash under running water for 10 minutes. Report immediately to the concerned safety officer. Assessment of post-exposure prophylaxis and post-exposure prophylaxis if required. Don'ts is first important thing is don't be panic. Don't squeeze blood from the wound and don't place the prick finger into the mouth, which is a reflex action. Do not use antiseptics and detergents. It is because that studies have proved that there is no known benefit in doing all these by squeezing the blood from the wound or using any antiseptics or detergents will not prevent that. Then coming to splash injury, irrigate whatever be the site for at least 5 minutes. If eye splash occurs, sit in a chair, tilt the head back, ask someone to pour water over the eye. If there is, if the person is wearing contact lens, it should be removed only after the cleaning is over. Never remove the contact lens immediately because in that this contact lens can act as a barrier, so that after removing all the contaminated materials from the contact lens, you can remove the lens. Then another important is mouth splash, spit out immediately and rinse with water. And another important point is that we are lucky that we are having a safe and effective vaccine which offers around 98 to 100%, already mentioned by the previous speaker, which gives around 98 to 100% protection against hepatitis B infection is available for us. The point to be noted is that the hepatitis B virus survives in the environment and can still be transmitted from dirty needles, surfaces, and contaminated waste for up to a week. It's up to 7 days. So during this time, the virus can still cause infection if it enters the body of a person who is not protected by the vaccine. So all healthcare staff must be vaccinated against hepatitis B 0, 1, and 6 months. That's the course of the vaccine. And titer level 4 to 6 months after the last dose. Booster dose does not require if the titer is more than 10. And post-exposure prophylaxis. The two important points are the pre-test counseling and sample collection and consent for testing, which is very important. So let me give you a brief description on how we should approach a person who had exposure. So definitely if a person had exposure, we should find the status of the source. The source can be either HBsAg positive or HBsAg negative, or the source not tested or unknown. The exposed person can be either unvaccinated, previously vaccinated non-responder, or previously vaccinated non-responder, or the response is unknown. So if the exposed person is unvaccinated and the source is HBsAg positive, definitely immunoglobulin and initiate one dose and initiate the vaccination. Then HBsAg, the source is HBsAg negative, or if the source is not tested or unknown, initiate vaccination. Then previously vaccinated non-responder, then you should test for the anti-HBs antibody. If it is adequate, no further treatment is required. If it is inadequate, that is, it is less than 10, HBV booster is needed. If the source is HBsAg negative, no further treatment. And also if the source not tested or unknown, also no treatment is needed because the person is safe. Previously vaccinated non-responder, then either immunoglobulin 2 doses or immunoglobulin 1 dose plus 1 dose of hepatitis B vaccine. HBsAg negative, no further treatment is needed. If the source is of high risk, treat as if the source were positive. Then if the response is unknown, then you should definitely test for anti-HBs if the source is HBsAg positive. And if inadequate, immunoglobulin 1 dose plus HBV booster dose. If adequate, no further treatment is needed. If HBsAg negative, no further treatment is needed. Source not tested or unknown, then test for anti-HBs. If inadequate, HBV booster. If adequate, no treatment. Seems this graph, this table may be a little confusing, and it is difficult to understand, but it should be in your pocket, because whenever a exposure occurs or needle stick injury, whatever occurs in your lab, you should be aware that there is a protocol existing for this post-exposure prophylaxis for hepatitis B. That's why I mentioned this table. Hepatitis B immunoglobulin or vaccine should be administered within 24 hours. Both can be administered simultaneously but at separate sites. The dose of immunoglobulin is 0.06 ml per kilogram IM. Adequate anti-HBs titer already mentioned is more than 10. And coming to hepatitis C, the immunoglobulin and antiviral agents are not at all recommended for post-exposure prophylaxis and after exposure to HCV positive blood. Perform a baseline for anti-HCV and ALT activity. Then perform a follow-up after 6 months. So a person who has taken post-exposure prophylaxis should refrain from blood or tissue donation. Sexual intercourse should be protected, and pregnant women should be advised against breastfeeding. So this is a recommendation followed up, recommended for lab test. Weeks 2 and 4, if the person is taking PEP, transaminase and complete blood count, and persons not taking PEP, clinical monitoring for hepatitis. Week 6, HIV antibody in both cases. Month 3, HIV antibody, anti-HCV and HBsAg for both groups. Month 6, HIV antibody, anti-HCV, HBsAg for both groups. And depending upon the finding, it should be managed. So the take-home messages: regard all waste soil with blood or body substances as contaminated. Wear gloves when contamination with body substances is anticipated. Do not touch your eyes, nose, or other exposed membranes or skin with gloved hands. Do not leave the workplace and walk around the lab wearing gloves, which is a common practice observed in most of the clinics. Wash hands after contact with blood or body fluids and after removing the gloves. Do not recap the needles. After use, needles, syringes, and other sharp items should be placed in puncture-resistant containers. Clean and disinfect blood or body spills with appropriate agents. And the most important thing is the vaccination of all the clinical. It is all the clinical and lab workers or who are working in your clinic against hepatitis B. Think today to ensure a better tomorrow. Thank you.
Madam, as there are no questions in the chat box, I would like to ask you a few questions, okay? Ma'am, I think you have two popular vaccines in the market. One is Recombivax HP and Engerix B. Is there any difference in the efficacy of these two vaccines for hepatitis B?
The difference is not much marked. Both can be used. Both are recommended.
Okay. Madam, I think what is your advice for dental surgeons, I think, who are into active clinical practice to keep away the menace of hepatitis B.
Regarding the vaccine, answer?
Yeah, not like that. The precautions to be basic precautions to be followed in the dental clinics. That is,
Before starting the clinic itself, you should take the vaccine. And the point to be noted is that after completing the dose, you should test whether you are a responder or not. That is the most important thing, because we don't know the most of the people, I think, in this they take the 3 doses of vaccine that
okay.
they are the staff working in your clinic. So the anti-HBs titer should be looked into, and if it is less, you should take the booster dose.
Okay, ma'am, there is a question in the chat box from Dr. Sheena M. If the vaccination series is interrupted, does it needs to be restarted again?
Restarted, yes, it needs to be restarted.
Okay. And one more thing, for example, if a person becomes positive with a hepatitis B, what is the strategy? Or is there any life-threatening situation always?
Okay, if a person as a healthcare worker or any other person who is found to be hepatitis B virus positive, then the next step you usually follow in our clinic is we do the PCR. That is, it is a real-time PCR we usually do. That is, we want to know the viral load of the patient. Quantitative assessment, that is the real-time PCR, that is what we are saying. We quantify the viral load of the patient. So combining this, the viral load and the clinical status of the patient, both things will be considered for starting the treatment. If the viral load is very low and the patient is asymptomatic, we leave the patient for follow-up, but regular follow-up is a necessity. So depending upon this clinical status and the viral load, the decision, treatment decision is usually made.
There are claims by various Ayurveda doctors that there is a cure for hepatitis B. What is your take on that?
Regarding vaccination, sir, actually,
Yeah.
whenever a person is joining in a clinic, like dental or any clinic, they're supposed to give 0, 1, and 6 vaccine, and take you find out the anti-HPSG titer also. And if it is less, the best thing is to retake the vaccine, and that vaccine anti-HPSG titer has to be documented. And if there is no documented evidence for vaccination, you are supposed to retake the vaccine. If some inspection or something comes, the ideal thing is you take vaccine for all the staff and it has to be documented. If it is not documented, it is not accepted. And Ayurvedic medicine, the thing is that, this liver is the one where all the metabolism occurs. In Ayurvedam, lots of plant products are there. So that what I feel is that will increase the problem, cirrhosis, carcinoma, because the metabolism occurs in the liver. So that will add on to the harm.
So another question is asked, can we able to take the hepatitis B vaccine after COVID vaccine administration? It is 4 weeks gap is recommended after this COVID vaccine and any other vaccine, that is including hepatitis B vaccine. After 4 weeks taking the COVID vaccine. Another is, what is the protective titer range? It is more than 10 international units per ml. First question. Another question is, why is hepatitis B vaccine not given to everyone as part of prevention like normal? It is given. It is given to. It is a part of national immunization program given to pediatric group.
So nowadays, hepatitis B is given as 016. For adults, it is 016. But for infants, whenever a baby is born, it is given as about 6, 10, 14 weeks, even along with DPT vaccine as pentavalent vaccine. So it's mandatory and it is free of cost also. So now it is
part of the immunization program, national immunization program.
Ma'am, one more thing. You have taken the routine vaccine at 0, 1, and 6th month. Okay. See, how long will the efficacy remain? For example, if I am testing my antibody titer after 3 years, and if it is found to be low, should I have to repeat the entire pattern again, the 3 doses?
Actually, sir, that's what I was telling initially. If you are taking 016, after 1 month, you check for antibody titer and document it. If it is more than 10, that is protective. And if it is less than 10, you have to retake. Otherwise, the problem is that our body plasma cells will release plasma cells, B cells, all this will release these antibodies. And as a part of normal damage to cell, the titer will be reduced. But whenever there is a second exposure, definitely the titer will be increased.
Okay.
So that's the importance of being booster also. That's the importance of documentation also. You have to document the anti-HBs titer. Then you are safe.
Okay. Now, let me just check whether our chairman is there actually. He wanted to speak to the sir is not there. Now may I invite our beloved and dynamic principal, Dr. Sudhibas, for the vote of thanks.
Thank you, Rajesh Pilla, sir, for inviting me to render the vote of thanks. Respected Taha sir, PG Director Dr. Rajesh Pillai, Administrator Dr. Biju, respected speakers of the day, my dear colleagues and my dear students. Today we got an inside knowledge about the precautions to be taken against hepatitis B infection. As dental surgeons, we are in high risk group. So this presentation was very much valuable for our fraternity. A special thanks goes to both the doctors for giving such a knowledgeable talk. Thank you, madams. And thank you, Dr. Shifi. Thank you, Dr. Shifi and Dr. Rafida, for sharing your valuable views.
Yes.
And I take this opportunity to thank our beloved chairman who who gave his valuable support and guidance. And our sincere thanks goes to Dr. Rajesh Pillai, Dr. Biju, Dr. Sheena, Dr. Smita, Dr. Ambali, and Mr. Sujit for their valuable support. Last but not the least, I thank my sincere thanks goes to our fraternity, our faculty members and students for their support. Thank you one and all.
May I request our chairman, Dr. P.S. Taha, to have an interaction with the audience, sir. Sir?
Yeah, just a second. I'm sorry, I am actually, in my office. I'm still working here. Okay. Anyway, thank you for Dr. Shafi Fazal and Dr. Rafida for the wonderful lecture. And hepatitis B, now we are in the midst of a pandemic by a virus infection. And the last 5-10 years, we have been, going through the hepatitis B also and hepatitis C infections. And this is a more risky affair for the dental, for the dentist. And this is a real eye opener for the dentist and the medical profession for this type of lecture. And I thank Shafi Faisal and his colleague for this wonderful lecture. Thank you very much.
Thank you, sir.
So thank you, and it was a very memorable webinar, and we really appreciate the effort you have put in for our webinar. Thank you very much.
Thank you.